Welcome back to 12 Days in March. I'm tossing this recording out there to let you know I'm alive and well, but busy redesigning the review course at the medical school. In this special edition of the Year in Review, I'll present a patient from my practice, taking some liberties with her presentation to emphasize important teaching points. So in this case, we'll discuss a patient who presented with palpitations. As with other cases, I'll present 4 questions for discussion. Please pause the recording to determine the correct response for each. Then we will review the material in painful, excruciating detail. Good luck. And here's our second question. Relax and enjoy the music while pondering this one. And here's the third fun question. And finally, a question on the ever-popular measures of coagulation. Answer this one and then we'll get started on our review. Alright, the most important teaching point here is that patients get sick at the most inconvenient of times. On this occasion, it really was my first patient of the day. Be that as it may, we note an irregularly irregular rhythm with a heart rate of 157 in a relatively asymptomatic patient. On the boards, if they give you a patient with fast AFib, more likely than not, it will be a setup for congestive heart failure. But in this case, the vignette specifically tells us there is no congestive heart failure. That is, when they go out of their way to mention no S3, it is their way of excluding CHF. So I mentioned atrial fibrillation is the underlying rhythm disturbance. The EKG is included, but when they mention irregularly irregular, you don't even need to look at the graphic. That said, I've mapped out several RR intervals so you can see their irregularity. If you use the blue arrow for one interval and compare this with the other RR intervals using the black arrows, you can see there is an irregular pattern. I emphasize the RR interval instead of the absence of P waves, as the boards are tricky and students sometimes confuse coarse fibrillatory waves with P waves and miss atrial fibrillation as the underlying rhythm disturbance. So now that we've confirmed the underlying rhythm, we can come back to our question. What is the principal determinant that governs her ventricular rate? The language of the question is intentionally misleading. It sounds like they want you to identify how to make the heart beat rapidly, but the question is really asking why her heart rate is 157 as opposed to the 400 beats per minute occurring in the atrium. They're simply asking the physiologic basis for this disparity. And the answer is the refractory period of the AV node. In AFib, the fibrillatory impulses need to travel through the AV node to trigger ventricular contraction. The heart rate is determined and limited by the AV node's availability to conduct the next impulse. Although rudimentary, students don't necessarily appreciate this key and recurrent target of inquiry. In fact, the meds we use to control the heart rate in atrial fibrillation all prolong transmission through the AV node. I include a list of meds you are likely to get tested on, including beta blockers, non-dihydropyridine calcium channel blockers, digoxin, adenosine, as well as carotid massage. Any of these may appear in questions that focus on heart rate control from supraventricular rhythm disturbances. I also include an important graphic that you should be familiar with. Specifically, you should be aware that agents which prolong AV node conduction do so during phase 4 of the action potential. You may be asked to identify this site of action. And here is a brief summary of the other responses with a word on why they are incorrect. So let's move on to question 2. We are asked about the basis of her myocardial injury. The graphic displays a minimally elevated troponin. So we have injury and mild elevation of troponin. By definition, therefore, we already know the patient did not have a myocardial infarction. More likely than not, the question is focusing on demand ischemia, which occurs when there is a mismatch between oxygen supply and demand. And the key point is made that the patient may or may not have occlusive coronary disease. That is, you can outstrip oxygen supply even in the presence of normal coronary vessels. The prevalence of demand ischemia will continue to rise as the troponin assays are becoming increasingly sensitive. Returning to the vignette, we are informed that an EKG has no evidence of ischemia. The patient has no history of chest pain, and she was referred for a stress test that was normal. How many other ways can they tell us this patient does not have occlusive coronary disease? So in spite of known myocardial injury and mildly elevated troponin, they have informed us she is devoid of occlusive disease. So we can exclude the first option, which would be the description of ST elevation MI. The second option, plaque rupture with partially occluding thrombus, is seen in unstable angina or non-ST segment elevation MI. However, the normal EKG, mild injury with negative nuclear perfusion study essentially eliminates the second option. As for the fourth option, wall stress during systole does compromise coronary blood flow, but this is not the basis for myocardial injury. Recall, coronary artery perfusion is predominantly a diastolic event. So the fourth option reflects normal physiology, but is not the basis for injury. As for the fifth option, rapid AFib is certainly accompanied by a neurohumeral response due to poor peripheral perfusion. As a result of both beta-1 and alpha-1 stimulation, afterload will increase with a resultant increase in myocardial oxygen demand, but this is not the best explanation for her injury. So that leaves us with diastolic duration as the correct response. This patient is tacking along at 150 beats per minute. Coronary artery filling takes place during diastole, but at this heart rate, coronary perfusion is impaired. Consequently, myocardial injury occurs as a result of the shortened period of diastole. And here is the graphic display of what we just discussed. During phase B, with the onset of systole, coronary blood flow rapidly declines owing to myocardial compression of cardiac capillaries. If you look at phase C, and/or the accompanying graphic, you can see that coronary blood flow is recorded as maximal during onset of diastole. This isn't rocket science, but they want you to understand this unique teaching point, and atrial fibrillation is a convenient way to test your understanding. Let's move on to question 3. They are asking about drug treatment for atrial fibrillation and giving us a bunch of pulmonary information. So let's start by interpreting the information offered. We note the patient is experiencing dyspnea. She still has no S3, so they are telling us there is no CHF. They did omit the pulmonary exam. Obviously, this was intentional. The chest x-ray is abnormal and difficult to interpret. There are interstitial changes, and I can see some nodular densities. Although we'll better understand this after interpreting the PFTs, the chest x-ray does demonstrate interstitial disease. Generally speaking, in vignettes with interstitial lung disease, the physical exam usually is included and mentions the presence of dry crackles. Even if we can't interpret the chest x-ray, the PFTs are unambiguous. Decreased FEV1 and FVC with a normal ratio. This is diagnostic of a restricted process. Next, we look at the volumes, and these too support pulmonary restriction with a decrease in total lung capacity and residual volume. And finally, we review the diffusing capacity of the lung for carbon monoxide, which is abbreviated as DLCO. This too is impaired at 64% in normal. But what does this mean? Impaired gas exchange, as assessed by DLCO, is consistent with 3 and only 3 disorders: pulmonary vascular disease, disorders of the interstitium, and loss of alveolar surface area, as seen in emphysema. You'll be seeing this description the whole rest of your professional lives. When interpreting PFTs, and especially the diffusing capacity, you will need to perform the clinical correlation. This means understanding the history, physical exam, and chest radiograph. So we have a patient with known restrictive lung disease on spirometry and measures of lung volumes. There is a reduced diffusing capacity and an abnormal chest x-ray. With this information, we can eliminate pulmonary vascular disease given the abnormal chest x-ray and restricted pattern. We can also eliminate emphysema given the pattern of restriction on spirometry and lung volumes. So we are left with a pattern of interstitial lung disease. And now we can return to our question. We are looking for an agent that is used to treat atrial fibrillation and is complicated by interstitial lung disease. Further, we know this is 6 months later and the patient has been restored to normal sinus rhythm. So what agent restores rhythm and can mess up the lungs? Obviously, they are talking about amiodarone. And here we have yet another example of how they play the pharmacology game. They give 1 or 2 components and expect you to fill in the blanks. In this vignette, they gave you an indication and an adverse effect. You needed to deduce the derivatives that follow, namely the agent and/or mechanism of action. So back to the question, let's sort out our mechanism of action and see how it might affect the EKG. I show Grandma Smurf to remind you that amiodarone can also cause blue skin discoloration. This case would have gone quicker if I just showed you Grandma Smurf to begin with. I'll do that next time. Alright, to finally end this torture, let's jump to the correct answer. Amiodarone is a potassium channel blocker. The point I want to emphasize is that blocking the potassium channel prolongs repolarization. Got that? The QT interval, and especially the T wave, is the portion of the EKG that correlates with repolarization. This should be easy to remember. So amiodarone does not affect the QRS complex. Its adverse effect would be measured on the QT interval. If we want to impact the QRS complex, you need to use a class 1 agent. These block the sodium channel, which is associated with depolarization. So if you prolong depolarization or phase 0, it is easy to see how the QRS will widen. And just for completeness, amiodarone does block AV nodal conduction, and the result is prolongation, not narrowing of the PR interval. The last option refers to calcium channel blockers, which do not affect the QT interval and are not associated with interstitial lung disease. So let's bring this bad boy home with everyone's favorite, tests of coagulation. This is important stuff, so go refresh your cup of coffee or pop another Ritalin. The question simply asks the coagulation profile for patients taking 10A inhibitors. And in this case, if you weren't aware, the 10A inhibitors are easily identified by the 10A in their product name. So let's dispense with the bleeding time column straight away. The bleeding time assesses platelet number and function. They love to include bleeding time options in coagulation questions, but the vignette has no, as in 0, reference to platelets. No nosebleeds, no bruising, not even a little band-aid. So the bleeding time is dead normal in patients taking 10A inhibitors. Once you appreciate this information, you should pray for them to include this column in coagulation questions. Insofar as disturbances of bleeding time, I've listed the qualitative and quantitative disorders for your convenience. At the least, make sure you are familiar with von Willebrand's disease. That's a board's favorite. So let's eliminate these 3 choices. Moving along, let's brush up on tests of coagulation. I'm including the common pathway for your reference. You are highly encouraged to be fluent in this pathway. No dinner tonight if you can't reproduce this from your mind's eye. I just reproduced it, so I'm having a lobster dinner. Just kidding. I didn't really reproduce it. So where was I? So you can see I've listed the intrinsic and extrinsic pathways that result in the conversion of inactive factor 10 to activated 10A. Once activated, thrombin is generated and a secondary hemostatic plug is subsequently formed. In a laboratory, this process takes seconds, and this is reflected by the PT and PTT. Tissue factor, or thromboplastin, is added to the patient's plasma and the clotting times are measured. So back to our patient, we are talking about 10A inhibitors. If we block 10A, how will that affect the 2 clotting pathways? Right, they're both prolonged. A secondary hemostatic plug cannot be generated and the clotting times are prolonged. So we're down to our last 2 choices. We need to understand the thrombin time to answer this one correctly. So how do 10A inhibitors affect the thrombin time? And by the way, it is easy to remember this stuff if you understand the pathways rather than trying to memorize test results. In fact, I try not to memorize anything, including birthdays and anniversaries. Sometimes this gets me in trouble. So how is the thrombin time measured? It is measured by adding some thrombin to the patient's plasma and then measuring how long it will take blood to clot. That's easy enough and looks delicious. So here we are again. Our patient is on a 10A inhibitor. It blocks the conversion of prothrombin to thrombin. No thrombin, no clot. But in the thrombin time, we don't need prothrombin or 10A. We're adding our own preformed thrombin. We have bypassed the steps involved in thrombin generation. So what happens to the thrombin time in patients on 10A inhibitors? It is normal. The 10A effects are upstream from the pathway that is being tested. So how can we elevate the thrombin time? This is pretty straightforward. We can eliminate fibrinogen to elevate the thrombin time. It also turns out that fibrin degradation products interfere with thrombin conversion of fibrinogen. This might be seen in DIC or following treatment with TPA. The other way to prolong the thrombin time is with thrombin inhibitors, and that makes sense. These include the direct thrombin inhibitors such as dabigatran or hirudin, or patients on therapeutic heparin, which will also elevate the thrombin time. Remember, heparin binds to antithrombin 3, with antithrombin being the operative phrase. So here is our answer. 10A inhibitors elevate PT and PTT without affecting thrombin time. Well, congratulations on answering these 4 questions and exploring some derivatives along the way. Look what we discovered. We sorted out the ventricular response in atrial fibrillation, exploring the AV node refractory period. We played around with pathways of myocardial injury, that are not from occlusive coronary artery disease. We touched base on amiodarone while exploring the different ways that USMLE will come after you with pharm questions. And finally, we dipped our toes back in the hematology waters, exploring contemporary anticoagulant therapies and their effects on coagulation parameters. Gosh, I hope you had a nice visit. This was a great interlude, but it'll be a couple of months before I ramp up video production. Just wanted you to know I'm alive and well, but busy with course preparation. If you have any questions or concerns, please don't hesitate to drop me a line. Nice to chat with you again.